Good morning, everyone. I have no relevant disclosures. So, I'll be talking about small and diseased access vessels and how to manage them. But before we even get to there, it's important to define what's considered small. And so that really depends on the endograft that you're putting in, right? If you're putting in a 20 French device, then a 6mm vessel may be small. If you're putting in something much lower profile, then that may be adequate. So I think knowing the device that you need and planning for, A, B, C, and knowing what those devices are and what the sheet size are is important before you begin. So what's considered disease, besides the diameter, degree of stenosis, the degree of calcium, whether it's circumferential, because that may be less likely to expand and accommodate a larger sheath, and then tortuosity is also a factor. So some treatment considerations in general. If you know you're dealing with a small and diseased access vessel, consider a lower profile device, especially if you think you can achieve the same kind of technical success that can give you an advantage. I think pre-treating the vessel is key, and we're going to talk about that in just a minute. And then obviously have a high suspicion of index for any sort of iliac injury, shoot a completion angiogram, and have your bailout options ready to go. So these are all the, some of the treatment options that we have, so we'll go through it one by one. So the first is if you're dealing with a common a diseased access vessel, a femoral artery, always consider doing a femoral cut down. It's a safe option. It has a low morbidity, and it can be done under local and sedation. And you can have direct visualization of your artery after you remove your endograft and repair it on the spot. So I think this is always should be a consideration if you know that your disease is in the common femoral artery. Some other traditional methods that we've had, if you're dealing with small access vessels, is considering balloon dilating it with increasingly large balloon diameters, or using a dilator before you put in your device. So this is probably adequate, for mild to moderate, I would say, iliac disease and those that have soft plaque. But now we have more advanced methods and technologies. So one of the methods to kind of handle diseased vessels is what we call crack and pave. So this is covered stenting with aggressive balloon dilatation afterwards. So you size your stent to what diameter you need, and then you use a high pressure balloon to post dilate it, and you're essentially having a controlled rupture of that vessel. But because obviously you have a covered stent there, you're not going to run into the issues of extravasation. I think with this sort of technique, you have to be very mindful of your endpoints. So, your endpoint at the common iliac artery and your endpoint near the hypogastric, if you're trying to preserve that, because those are areas that you could disrupt where you can't really seal that easily. In terms of the data, there's not too much, but this study was from 2017 looking at the crack and pave technique. It was a retrospective study of 19 patients who underwent EVAR. And what they found was the patency of the intervention was very good. So out at 17 months with basically lining your iliac artery with covered stents, the patency was 88.9%, primary assisted patency. And in terms of kind of intraoperative complications, it was very low. I think they had 0 ruptures in this study with a good midterm patency result. The other technology that has come around that I think we're using more increasingly that has a lot of value in small and diseased vessels is intravascular lithotripsy. So this is an excellent adjunct to treat calcified vessels specifically. And it delivers, as we know, sonic pressure to kind of crack the calcium to make the vessel more compliant for your large sheath. So prior to, more aggressive angioplasty, stenting, or insertion of the large sheath, you can use intravascular lithotripsy to increase your compliance. And really there's, I would say, little downside from this aside from cost and a little bit more time. There's a study that came out recently with some very familiar names here, looking at lithotripsy to treat large bore vascular access during EVAR, TEVAR, and TAVRs, and it was a retrospective review of 9 patients. And what they found was they were really able to expand that vessel to much larger diameter. So it was a 229% effective luminal gain. They had 100% technical success, 1 vessel perforation, which was managed with a covered stent, and a good kind of no long-term complications from the access site. The other option that should always be considered is the iliac conduit. So if your external iliac and your distal common iliac artery is very diseased, doing a small cut down, a retroperitoneal incision, and then sewing a graft onto that is another way to kind of bypass that disease segment and then just over sewing it at the end. And so before the endoconduits, I would say this was more common. In terms of how they compare to each other, so this study was from 2014 that basically compared open conduits to endoconduits. And it was a study of 39 patients who underwent TEVAR, and they had a median follow-up about 10 months. And what they actually found was the open conduits had a higher rate of complication, 26.1% versus 12.5%, which wasn't significant. But notably, they had more retroperitoneal hematomas, infections, and wound complications. So their conclusion was the endoconduit is a safe and effective treatment with a low rate of morbidity and mortality. And then, of course, if you can't come from below, you can always think of other options. So coming from the arm, so an axillary or brachial cut down. You can accommodate large sheets from this way as well. There are some limitations, of course, because you're reversing the device. So you may need some back table modifications. But this should be another option that should be considered. So for the sake of time, I'll end with a case here. So this is a 81-year-old male who had a 4-centimeter saccular AAA with associated aortoiliac occlusive disease and non-palpable femoral pulses. And he had a pretty significant claudication in both legs with a multi-level disease on the left side with rest pain. So I think the key points for this was you're dealing with both an aneurysm and his iliac disease, so trying to address both given the kind of high-risk morphology of the AAA. Of note, his right external was already occluded, so the plan was to try for an AUI and FEM-FEM. So here's just some angiograms here, so you can see that saccular aneurysm in the distal aorta. Farther down, you can see a pretty significant stenosis at the origin of the common iliac artery, as well as a lot of calcium in the vessel farther down. And then that just shows that really tight common iliac artery stenosis higher up. And then farther down, you see in the external iliac where it's pretty much nearly occlusive with just the micropuncture sheath. So for this patient, this is a kind of a great case, I think, that we can use some of these adjuncts. So the first thing, given the degree of calcium, is we did an intravascular lithotripsy with kind of larger balloons, so I think a 6 and a 7 shock wave. You can see there's already a lot of improvement in the diameter of the vessel just from this alone. So after this, I felt, I ballooned it and I felt pretty good about putting my sheath in, but unfortunately it still had a hard time tracking. So the other kind of option I had, which we discussed, is the crack and pave technique. So I put in some VBXs and Viabonds and then went up with a high pressure balloon to really open up that external iliac artery where it got stuck. And through that, I was able to deliver the endografts. And then here's just a completion where you can see pretty good seal of the aneurysm and resolution of the stenoses. And then farther down, you can see that I left a little gap since he was a claudicant to preserve his hypogastric as well. This patient did well. 1 year follow-up is, has exclusion of his AAA. So I think in conclusion, access vessels traditionally have been the Achilles heel in a way for aortic stent grafts. Now with multiple endovascular adjuncts, I don't think that's the case, as well as lower profile devices to aid with these complex access cases. And I think iliac conduit or endoconduit is a safe and tested option for the delivery of these stent grafts. Thank you.
Dr. Rao, thank you so much.